Good morning to everyone. We're going to get started. I'd like to welcome all of you to this symposium on comparative effectiveness research in prevention. This is part of our centennial events. As you know, we're drawing closer and closer to the end of the centennial academic year. The last event will be on May 28th, just the day before commencement. Throughout this academic year, we had a number of festivities, both commemorating our rich legacy and then looking towards our next 100 years. And I think the topic of today's symposium fits exactly that, because the Harvard School of Public Health has had a very, very rich tradition in leading this field since with some previous efforts. But since 1973, when Dean Howard Hyatt led an initial formal effort to try to assess, what are the effects of everything we do in the health system, and establish what was initially called the Center for Evaluation of Clinical Procedures, which was later renamed the Center for the Analysis of Health Practices, and which became really an intellectual magnet for people who become leaders in this emerging field. And then, of course, educationally, the program in clinical effectiveness has educated generations of leaders in this field. And from the beginning, acting at the intersection between clinical practice, epidemiology, and policy concerns, with a very strong quantitative approach and a mix that I think has informed some of the most important decisions on our increasingly complex health system. Of course, comparative effectiveness research really seeks to answer two fundamental questions: what interventions work and what interventions represent the best value, the best use of limited resources. And although most of the attention, both in the US but also globally, has been around clinical interventions, we believe, and that's the topic of this symposium, that equally important are public health interventions. And to my mind, when we talk of the health system, it encompasses all of that. The public health is not out there with clinical care down here. They are obviously integrated, and in fact, as this country moves towards implementing the Affordable Care Act, it's very important that it doesn't follow the path of so many other successful insurance reforms, which is that when you lift barriers, economic barriers to demand, if you do not simultaneously generate a series of upstream interventions to stop people from getting sick in the first place, the system will invariably become unsustainable. So every successful health reform has really built three pillars. Certainly financial protection through insurance is a major one, but assuring quality so that care actually accomplishes what it's meant to accomplish, and then accompanying that by a parallel set of interventions that act on upstream risk factors and determinants of poor health becomes crucial to not just to improve the final outcome, which is improve health both for individuals and for entire populations, but also to make the entire enterprise sustainable. So this, at this particular juncture, historical juncture, this historical moment in the US health system, of the largest transformation, certainly since the 1960s with the passage of Medicare and Medicaid, but also in a global landscape characterized for a common shared search for better solutions. This discussion couldn't be more timely. And this has become even more so as complex health systems, which are really a phenomenon of the 20th century, really parallel the evolution of our own school. Because remember that before the 20th century, the social function of caring for sick people and preventing disease was really assigned to or allocated to undifferentiated social institutions like the family or religious institutions. It's only in the 20th century where you develop massive institutions hiring literally millions of specialized professionals and other workers with the sole purpose of improving health and taking care of the sick. This is the parallel health revolution of the 20th century. We tend to emphasize the tremendous epidemiologic and demographic changes. But in parallel, there was this enormous health systems institution. Today, health systems are the largest sector of the largest economy, the US economy, with 18%. And it is also one of the largest sectors of the global economy, with about 10% of global product being devoted to health, which is about $6.5 trillion a year. There's no industry of this size that operates with such a dramatic absence of understanding of what are the results of all of those investments. No other industry. And that's why comparative effectiveness research is absolutely critical as countries all over the world are seeking better value for those massive investments and growing investments. So this is the topic for today. Obviously, this, as I said before, we build on a very rich legacy of accomplishments. And I think Milt Weinstein has been one of those leaders that has really, in a sustained and incredibly productive career, has led the efforts. And that's why when I started my tenure as dean, now 5 years ago, I already represent 5% of the history of the school. I thought about the need for having something called flagship initiatives, not a large number. There are only 3 of those. And these were initiatives that would have several characteristics. One is they would involve multiple departments, because we have great departments, but many of the most creative activities are happening in the intersection among those departments. Second, they would tackle an intrinsically important problem from an academic point of view. But third, it would also be a very pressing issue on the policy agenda. And clearly, clinical effectiveness, even going back to the stimulus package, became a very, comparative effectiveness, became a very salient topic, but then has taken center stage with the Affordable Care Act. And it is truly an activity that engages many of our departments. The methods that have, many of them been designed at the Harvard School of Public Health from the beginning, emerged from multiple disciplines represented on our faculty: biostatistics, epidemiology, but also decision science, behavioral sciences, economics. Building on that legacy, now the flagship initiative on comparative effectiveness research is truly being a faculty and students from different departments and different members of our larger health sciences campus here in the Longwood area, with the purpose of further advancing the methods and the practice of comparative effectiveness research. So I'd like to welcome all of you today, and very especially Dr. Jeffrey Cullen, today's keynote speaker, who will be speaking a little bit later today. Jeff is a great friend, not just to me personally, which he is, but also to the university. He, among other things, chairs the visiting committee to the Harvard School of Public Health. So we're really honored that you could be here, Jeff. Thank you very much. And I also would like to recognize the efforts of the organizers of today's events, obviously led by Milt Weinstein and Stephen Resch, Christine Bell, and Laura Dalton. I hope you will enjoy. Remember, the word symposium in Greek means a banquet. It means to drink together, actually. But it evolved to being a banquet. So today we have adopted that Greek original sense to mean a banquet of ideas. And I'm sure that's exactly what you will have all throughout the day. So let me turn the podium over to Milt Weinstein, who has been leading our flagship initiative on comparative effectiveness research. Milt, thank you very much.
Well, good morning and welcome to all of you, our distinguished guests, Dr. Cullen, and members of the Harvard community and others. So what is comparative effectiveness research? The Federal Coordinating Council defined it as the conduct and synthesis of systematic research comparing different interventions and strategies to prevent, diagnose, treat, and monitor health conditions. So prevention was part of the initial concept that led to the current focus on comparative effectiveness research in the U.S. But our vision and scope is to broaden the attention to public health, as Dean Frenk said, beyond what the federal law, the Affordable Care Act, says. We believe that public health interventions should be part of the comparative effectiveness research agenda, and moreover, we believe that cost-effectiveness analysis and measures of health improvement, such as quality-adjusted life years, are important and indeed essential elements of CER. And some of the papers, some of the talks you'll be hearing this morning do include cost, even though the Affordable Care Act specifically avoids including cost in the definition, in their definition of comparative effectiveness research. We have a variety of topics in the realm of prevention and public health: obesity, air pollution, worksite health promotion, injuries and violence, vaccines, dietary policies, and some distinguished faculty members to speak on those topics. One topic that we don't have on the program, not by design, but just because it didn't fit into the schedule, is tobacco, obviously an important public health risk factor. As Dean Frenk said, at the School of Public Health, we have been at the forefront of methodology in this area, and you will see in the talks today examples of the use of prospective trials, the use of observational data to make causal inferences using some innovative methodologies that were developed here at the Harvard School of Public Health, cost-effectiveness analysis and mathematical modeling, among others. I just want to mention again, if you were thinking of leaving early, don't, or you'll miss Jeff Copeland's talk. Jeff is an alumnus of the school, one of my first students, and I'll say more about Jeff when I introduce him later in the day. So without any further ado, I would like to move on and introduce, I was instructed to give some reminders about the logistics of this facility. There are restrooms. If you go out the door to your right and turn left, you will see the restrooms. And there are exits both to the right and to the left.